Thanks, Stefania. Well, just to introduce myself, I'm an infectious disease epidemiologist, so maybe I will bring here a different point of view. And actually, before giving this presentation on the public health impact of several vaccine-preventable diseases, I would like to provide some conceptual support to the adult vaccination paradigm that is the topic actually of this, meeting. Actually, adult vaccination can be seen as a natural consequence of population aging. We could just say, you know, people live longer, there are more and more old people all around the world, and so it's natural that we'll start programs to prevent infectious diseases among the older population. But we have to raise at least two questions in order to deal with this problem. One is, are vaccine-preventable diseases a public health problem among adults and the elderly? Most of us would say, of course, but we have to provide numbers to demonstrate that. The other question is it important to implement vaccination strategies among older individuals? Because, you know, when we vaccinate younger people or even adolescents, we can create herd immunity, and we can think that we don't need to vaccinate older individuals just because of the herd immunity effect. So I think we should, in some way, to think about the data and also the effect of vaccination among children in order to decide whether it's useful or not to vaccinate also the older individuals. So another question that I want to raise is, does children vaccination protect older adults? Because I think this is a crucial question, a key question. Because the effect of the immunization in the community, of course, goes well beyond the target group that is vaccinated. And the level of protection in one age group may modify the level of protection in the other groups that are not targeted by vaccination programs. So this is what we may call an indirect effect. Then vaccination strategy applied to vaccinate a specific target group. For example, take the case of children. They are, in real terms, amplifiers of epidemic amplifiers, may modify the epidemiology of a disease in all the other groups, in particular in the elderly, because take the case of influenza. Schools are disease amplifiers, epidemic amplifiers. Then influenza is brought into the families by the children. So if I vaccinate the children, for example, I don't need maybe to vaccinate the older adults. So this is, I mean, something that we have to deal with when we start thinking about vaccination programs in the older population. So the point is, the real question is, do we need to vaccinate older adults or not? And of course, infectious diseases continue to spread because of insufficient herd immunity. So we know that even though we vaccinate children, usually infectious diseases anyway are not put under control, kept under control necessarily. This may be due to low vaccination coverage among children. Take the case of measles, for example. In Italy, we have now an outbreak of measles that is quite impressive, even though we have relatively good coverages among children, or germ circulation among adolescents and older age groups, for example, with Neisseria meningitis. We just had an outbreak of meningitis, meningococcal meningitis in Tuscany, even though the vaccination coverage among children was quite good. So we had to think about this also. Another point is a high proportion of adults does not acquire immunity through natural infection with several biological agents. And this is another point that we have to consider, because sometimes we say, you know, most adults got the infection when they were young, but it's not like that anymore in many of our societies. And the other point is that protection does not last forever. So there's waning immunity with increasing age. And we have to take this into account when we think about protecting older adults. So there is a need, probably there is a need of a direct protection of adults and especially older individuals. This is the reason why, for example, in Italy, just 1 year ago, we started with the new national vaccination plan, including vaccination of older individuals. And this was this plan actually followed pressure by scientific societies that launched the so-called calendario vaccinale per la vita. There is a lifelong vaccination calendar that has been one of the main determinants of the decision of the government to implement this lifelong vaccination schedule. So starting with preventable diseases among the elderly, actually, we had to mention, first of all, of course, the so-called cursed triad. That includes influenza, of course, pneumococcal pneumonia, and herpes zoster, that we call fuoco di Sant'Antonio, St. Anthony fire. I don't know if everybody could use this nickname for the herpes zoster. Actually, influenza is the most, of course, used. The anti-influenza vaccine is the most used vaccine in Europe, and most European countries have vaccination programs to protect also older individuals against influenza. We don't have. One of the problems is that we don't have accurate numbers about the dimension of seasonal influenza waves. The European Center for Disease Control estimates that every year between 5 and 15%, so the range is quite large, of the population each year develop influenza. So that means between 35 and 100, more than 100 million cases every year. It depends on the seasonal activity of influenza. Sometimes we have very active seasons. Other times, as you know, we have a lower number of cases. And about 90,000 excess deaths, actually, that may be either directly or indirectly attributable to influenza. The excess hospitalization that is due to pneumonia, I mean, when we use the code, pneumonia or flu, actually we find about 50,000 excess hospitalization during the influenza season. There's a project in Europe that is the European Monitoring of Excess Mortality for Public Health Action, the so-called Euro-MOMO, that actually allow us to monitor the excess of mortality during the influenza season, and we see that every 2 years actually we see very high peaks in this case. But anyway, there's an excess mortality every year during the influenza season, and this is what we call indirect estimates of mortality attributable to influenza, actually, we know that individuals that are more than 65 years of age are the main target of the influenza campaigns in Europe, and actually they represent about half of the targeted population group for influenza vaccination. So quite a large number. The vaccination coverage is has wide variations throughout European countries. But for example, in Italy, we had quite good coverages up to 2 years ago, about 60%, but now the vaccination coverage is decreasing, and it's about maybe less than 50%. Of course, we have problems with influenza vaccines. Maybe Rino then will talk about it. And there are limits of challenges of this, the use of these vaccines among the elderly. In particular, among the elderly, we have a higher impact of H3 strains compared to H1 strains, and they usually create more problems regarding the vaccine and also vaccine virus and wild virus mismatch sometimes. And there is a lack of clinical trials, of course, for ethical problems, mainly on flu vaccines in the elderly. And so you see sometimes that for example, the people working in the Cochrane database, they say, you know, there's no evidence, scientific evidence of efficacy and also effectiveness of influenza vaccine, but just because there are no data, because the trials are not implemented just because of ethical problems. So sometimes we have a low effectiveness of influenza vaccines in the elderly, but you have to take into account that it depends on the season, because in some seasons we have a mismatch between the vaccine and the wild virus, as I told you before, and maybe there are possible advantages with the use of adjuvanted vaccine, but this is the matter of the topic of a next presentation. Pneumococcal vaccination also is quite widespread in Europe. Actually, Italy is in gray here, but actually it should be green in accordance with the new vaccination schedule. And what is important to say is that lower respiratory infections that include pneumonia is a leading cause of deaths worldwide, and especially in the elderly. And you can see that actually they are the fourth group in terms of mortality worldwide. In Europe, there are quite good estimates of the incidence of community-acquired pneumonia among different population groups, and you see that the incidence is quite high in over 65 years olds, and with 14, and it's about 14 per 1,000 person years. And it's also very high in people with chronic obstructive pulmonary disease, and most of them actually are old. The incidence of community-acquired pneumonia, of course, increases with age. This is not news, of course. And what is important to say is that Streptococcus pneumoniae actually is the most commonly isolated pathogen in community-acquired pneumonia. So most of them are preventable, vaccine preventable. And the trend in the notification rate of cases of invasive pneumococcal diseases in Europe is going down very slowly and very slightly. So you see that in the older group, the highest incident. Actually, there's a downtrend, but it's very, very, very slow. Even though vaccination has been started in some countries. What is important to say is that occurs the risk of pneumococcal pneumonia increases with age, and that is also dependent on several comorbidities. And you can see actually that people with diabetes have almost a threefold higher risk than people without diabetes to develop pneumococcal pneumonia, and of course people with chronic Lyme disease has an almost eightfold higher risk of developing pneumonia than people without COPD. It's another important point is that there are conditions that may favor the development of pneumococcal disease. At the same time, when you get pneumonial disease and you are old, actually your conditions may worsen, and people with 22% of people who had asthma after developing pneumococcal pneumonia referred that their conditions actually worsened, and the same thing with for other important comorbidities. Another important point in favor of vaccination is that pneumococcal pneumonia is associated with reduced long-term survival. You see people as a control, they used as a control group people with an average age of 63 years, and those who survived after pneumococcal pneumonia had a shorter probability of survival after 10 years following pneumococcal pneumonia. And another point always in favor of vaccinations is that the case fatality ratio of patients with pneumococcal pneumonia did not change significantly over the last decades. And this is an important point because actually that we had to consider when we have to decide about the implementation of vaccination programs. The other disease in the cursed triad actually is herpes zoster. Herpes zoster vaccination is not widespread throughout Europe, and now also in this case Italy should be actually yes, so blue. And of course, the risk of herpes zoster and postherpetic neuralgia increases with increasing age, and this is due to immunosuppressants. And you know very well, you know better than me this point. And there are estimates in Europe about the incidence of herpes zoster and the incidence of post-herpetic neuralgia in people belonging to different age categories, and you see that the incidence overall is 2 to 4 per 1,000 person years, but increases to 7 or 8 in people more than 50 years old, and up to 10 per 1,000 person years among the older group, among people more than 80 years old. Hospitalization is quite common in people with herpes zoster, and the duration of hospitalization also is not short. These are Italian data, maybe in other countries it's shorter, but the mean duration of hospital stay in this study conducted in Italy was 8 days. That is quite long actually, and also the costs are very, very, very high. In another study conducted in the Tuscany region, actually, about 4,500 hospitalization occurred during a 10 years period, and among those who were hospitalized, half of them actually were hospitalized without complications, and the most important complication, of course, was neurological, and in 24% of the patients, ophthalmic complications occurred in more than 16% of the patients. Estimating the cost is not easy, but actually in this study it was possible to estimate an average yearly cost of 1,200,000, more than 1,200,000 euros, and the cost for single hospitalization was more than 3,000 euros. So when we think about this number, we say, is it convenient to vaccinate or not? Also from the economic point of view, not only from the point of view of the patient, but also from the point of view of the government. Maybe actually it is convenient. Just a brief note to childhood, so-called childhood disease preventable by vaccination, because actually we are used to think that measles, tetanus, and pertussis they just affect young people, but actually it's not like that. And I was telling you about the outbreak we are having in this moment, actually in Italy, the outbreak of measles, and I had to say that actually the mean age of the people, the median age of the people affected by measles this year in this Italian outbreak is about 27 years. That means that most of the people affected by measles actually are adults, and so the complications are very common, and also hospitalization is very common. Almost 40% have been hospitalized, or the patients have been hospitalized, so the cost also of this outbreak is very, very, very high. So when you think about cost benefit, actually, I have to say I would prefer to vaccinate than having this outbreak. And you see also that these are European data of last year, and you see that the adults are very well represented among the cases. Pertussis also, is another issue, because also waning immunity is a phenomenon quite common after pertussis vaccination, and cases of pertussis are not uncommon among adults, and the adults especially women, may be a source of infection for the neonates. So vaccination programs for pertussis among the adults are actually needed. What happened? The last point is diphtheria and tetanus, anti-diphtheria and anti-tetanus vaccination, because we forget actually to booster our immunity with tetanus too often. And this is, for example, a trend of cases reported in Italy up to a few years ago, and you see that older women actually are a risk group for tetanus, especially older women living in rural areas. So we have still cases of tetanus. Tetanus is it's a very bad disease. Actually, they go to the intensive care unit, and so the costs are very high, and death rate also very high. So better to boost with tetanus. Best to remember people. It's much better to remember people that they should be vaccinated against tetanus, or if they had not done it within the last 10 years. So I think there are many challenges about the issue of vaccination among adults, and we have to remember that actually, even though we have to mention that even though we have different policies in Europe, there are also determinants of the different policies that should be considered. First, the epidemiology of diseases may vary actually across member states. We have to take this in mind. Adult migrant population may increase this variability. The scientific evidence on the burden of the vaccine-preventable diseases may not be available at the national level, so we have to rely sometimes we have to rely on data acquired by other countries, but country-adapted immunization schedules for adults may be, in this case, an option. And programs for adults should be monitored monitored as the ones for children in order to assess the impact and the effectiveness of vaccination. In conclusion, there's, of course, an increasingly older population. Comorbidity is very common in this population. The burden of vaccine-preventable diseases is more and more relevant. And the scientific data not always are sufficient to convince policymakers. That is the most important point, to adopt a more effective preventive strategy. So communication skills are actually needed in order to convince them. Thanks.
Thank you for your presentation. I have a question because when we look at the beginning of the session, we heard about disability, and you didn't say anything about the impact of the infectious disease on disability, much more on mortality, which is the traditional outcome parameters for vaccine. Do you think we lack a lot of data about flu, impact of flu on disability, impact of zoster on disability, or do you think we have enough and try to move the evaluation, assessment of vaccine efficiency on disability?
I think you are right. I think we lack data about disability because we are used, actually, especially epidemiologists are used to deal with, very, let's say, hard data, like number of cases, mortality, and sometimes data on disability are neglected. So I completely agree with you. We need more data. I mean,
you showed them some nice maps where countries which had the recommended and funded vaccination, the ones who didn't have funded. So the first question is there a large difference in uptake which is due to the funding of the vaccination? And does this difference, if there is one, result in, for example, a difference in excess mortality in the older population?
Oh, I had to say that those maps are produced by the CDC, the European Center for Disease Control. And we are supposed to give them the data. And then sometimes we are not able to read those data. Because if I show you the map about influenza in Italy is, for example, Italy was green or something like that. Maybe it was implemented but not funded, something like that. And I have to say that I don't know what does it mean, not funded. So you got a good point, because not funded means that the government did not allocate money just for that project, or that you had to pay for your vaccination. It's the first case, maybe, because actually older people don't have to pay for vaccination. So to me, I would like to see another map produced in another way and presented in another way, and just presenting, those countries that offer vaccination free of charge, those who don't offer vaccination free of charge, and countries that don't offer vaccination at all.
May I ask you a question, which is a following question? You saw us map concerning flu vaccine and pneumococcal vaccine. Flu vaccine in Belgium seems to be recommended but not funded, but pneumococcal vaccine is recommended and funded. Can you tell us more, or if one of our colleagues can say something about it in Belgium?
No, I have to say that actually it's more or less the same answer I gave to Francesca, because I think that these maps just can give you an idea about the use of vaccine, if vaccine is offered or not, but you cannot go in depth in those maps, because otherwise you get mad.
Well, my question regards the fact that there are adult people, old people, very old people, and very, very old. And there is an increased heterogeneity in old people. Some people are frail, some are not, some have comorbidities, some live 100 without anything. So my question is it possible to have data on for decades? Because a guy of 70 is completely different biologically from a guy of 90 or 100. So the data should be more, we need more granularity of the data. The second is that the trajectories of all the people are quite different by gender. And is it possible also to have data on gender difference between, especially in the old people, because biologically and for a lot of diseases, there are big differences.
Yes, of course, I agree with you. I mean, you need a 3 hours presentation because actually, in order to disentangle the effect of the single variables in different age groups, and also among people that are more than 65 years old. To be very pragmatic, actually, when you implement a vaccination policy, you just look at where are the risk factors and where is the excess mortality. And this is the reason why, actually, people that are more than 65 years old are offered vaccination free of charge. Because over 65 years, there's a concentration of risk factors that increase the risk of mortality for influenza and complication of influenza, for example. But I agree with you that the older you are, the higher is the risk of mortality after an episode of influenza, for example. And the risk gets higher and higher with aging. So I think it is possible, of course, to disentangle the data, to stratify the data by age group. But it depends on your objective. I mean, if it's useful or not. For academic purposes, of course. For implementing a vaccination campaign, maybe, if you want not to vaccinate too many people. But I think we are in the condition of offering the vaccination free of charge, at least in Europe, to people who are more than 65 years old.
You showed us the increasing incidence of tetanus, for example, in the European population, and also the increase of pertussis in the older population. Okay? Now, since, as you showed also, there are some countries which recommend and practice revaccination, how the mortality would change if you express the data just based on the countries which recommend and practice the revaccination for tetanus and pertussis, as compared to the countries where this is not used, like Italy, for example?
Now, in epidemiological terms, we call this kind of associations ecological associations. And usually they are very spurious. They are affected by confounding and biases. So this is why usually we don't do it, right? Because you have to control for many variables when you compare different countries with different policies. And it could be, a good exercise, but then you cannot conclude anything from this kind of comparison.
Because of the low numbers or because of the biases?
No, because of biases. Because of the fallacy of ecological comparisons. And the other point is that just because, Giuseppe, there are many factors, many other factors that can influence epidemic trends, for example. Take the case of measles. We can say, okay, we just compare, I mean, a country where there's an outbreak this year and a country with low numbers of cases, and we can look whether there are different vaccination policies. But as you know, outbreak measles occur every 3 years, for example, and there cannot be a synchronism between the epidemics in different countries in the same year. So it's what we call ecological fallacy.
Coming back on the funding issue, it's very complex because we think that when a national government issues a guideline, maybe funding will be done on a national level. But why it is not clear in Belgium is because there is no funding at the national level. For influenza, for example, there is only a partial reimbursement in Belgium on national level. On the regional level, there is a reimbursement, full reimbursement for nursing home residents and not for other older people. For pneumococcal vaccines, for example, there is no funding nationally, no funding regionally, but private insurances fund some reimbursement. So it's a very complex issue.
I agree with you, and also because I live in Italy. And we have 21 states, I mean regions, sorry, in one country. So I completely agree with you.
So can we just touch on the pneumococcal issue again? Most of Europe gives a single shot at PPV 23 at the age of 65. The antibody lasts at the most 5 years, maybe 6, 7. So it's gone by the time you're 75, 80. Take a look at the prevalence of pneumococcal disease. You have a high prevalence in the older individuals, those over the age of 80. You talked earlier about finding a vaccine which is going to protect a population in need. That's a population in need. What would you recommend that we do?
Can we discuss about it at dinner? But I agree with you. I mean, that's a good point, because also when we talk about this is like, you know, comparing different countries with different policies. In this case, we are dealing with the matter also of different vaccine and vaccination schemes that may be used and the effect of the different vaccination schemes. So it's a very complex issue, actually. I cannot give you an answer now. What we do in Italy is to recommend the 13-valent vaccine and then revaccination, boostering with the 23-valent vaccine.
This is sorry. Okay. This is Manuel Moro from the National Institute of Health in the United States. Maybe my question is it's too broad. It's out of the topic. Maybe it's not. I know it's not the topic of this conference, but maybe it's for a dinner question. But and excuse again my ignorance.
It's work dinner. I will stay. I will go in Venice.
But my question is more with deals with the bioterrorism. And is years ago I working a plan in the States to control a possible outbreak of foot and mouth disease in cattle, for example. Yes. As you know, foot and mouth disease is not really it will be a problem in humans, but it will devastate the countries of North America, well, every place that has cattle, even in Europe. So we're working a plan. So there's a plan that is ready if something happens. Now, but if we talk about humans here in Europe, and again, excuse my ignorance, I'm sure the countries here have coordinated plans. If, for example, I'm thinking it's only a matter of time that we have, I am surprised that we have had an attack, a bioterrorism attack with a potential one of these agents. of course, the United States is easier, it's one country, it's easier to deal with Canada, the US, and Mexico, for example. But Europe, you have different countries, different policies. So could you make a comment, if it's possible, about your coordination, your plans in the case of one of these attack of an infectious agent, and then you have to, for example, globally, vaccinate huge amounts of people?
Yes, actually, there are some plans, not with regard to bioterrorism, that was quite, in Europe was very fashion up to 10 years ago, and then it was forgotten. But about pandemic plans, because now there's a joint action. Actually, there's also a coordination in Europe for deciding, actually, in order to decide what amount of vaccine each country will receive, which kind of vaccine, and whatever else. So there will be a meeting, I think, next month, maybe on June, I think in Luxembourg, and I think that it will be decided also to make a common agreement in order to buy a certain amount of vaccines. But the decision also will depend on the single countries. So what the European Union asks us is to give numbers, to say, just to say, I need, how many, they ask us, how many vaccine you would need in case of a pandemic. And we say, how much money we had to spend to get how much vaccine. So, but maybe the EMA can give a better answer than me.
Yes, although, okay, there is an influenza pandemic plan which is public and you can access it. The point is twofold. One is the capacity to stockpile the vaccine, because once the pandemic is declared, the production will need to be ramped up. And so there is a waiver to the normal process to approve a new strain of vaccine because of the need to accelerate that. And the other is how much you will have. So that's a matter of national policy, who they will vaccinate first. And possibly it will be the essential services to let.
Yes, but Francesca, maybe there will be a joint procurement, as far as I know, and the joint procurement meeting will be held, I think at the beginning of June in Luxembourg. So, but we were, the Minister of Health asked us as a research institution to give them some estimates, to provide some estimates about the need of vaccine in case of pandemics, and it's a very tough exercise. So we had to discuss it tonight at dinner, before drinking wine, anyway.
I think there's a shared view in the audience of the complexities of associated with adult vaccination. The question that I think I'm raising is about political will. I listened to my colleague from Belgium, with all the different complexities, and Italy. You say that the complexities in Italy. I just put on the floor the issue of political will, because I think that what needs to be happening also is understanding of the calculated return on investment for adult vaccines, because what you've been talking about today, if we extrapolate it and we talk function and ability, and the ability of an older person to remain, in their home versus being hospitalised, etc. But do you know of a body of work around calculating the return on investment of adult vaccines?
Difficult question. What I can say is that, first of all, yes, I talked about complexities also in Belgium, also in Italy. But for example, now in this moment, actually. We have a strong commitment by the Minister of Health. Actually, the political will is very strong, and the new vaccination plan is really, there's a wide offer of vaccines for all ages in the new vaccination plan. The point is, where is the complexity? Is that also in a country like Italy, where the political will is very strong at the government level, then you have to deal with the regional level and with the organizational level. And so, you know, even though you have a strong political will at the central level, you may get difficulties in implementing policies when the local level is involved. So, and I think the same thing is also valid for can be applied also to other countries.
Gianni, to conclude, just tell me if you would agree with me in saying that geriatricians, as scientists, I think, should take the responsibility of having devoted too much attention in the last decades to chronic conditions and under-evaluated the impact of infectious disease, both on disability, that was the issue that Gavazzi mentioned, but also from the epidemiological point of view. I think that I fully agree with the ecological fallacy that we have to face when we study, particularly because of the heterogeneity of the population. But if, based on the comment before, we would make an effort to target specific subgroup of the population, I think that observational studies could really provide very, very important data that...
Of course.
Yeah. So that would be one of the efforts that I believe we should make. Thank you very much, Gianni.